Again, my name's Dana. I am a physical therapist and headache specialist. I treat people every day in the clinic who are living with chronic headaches. And so I wanted to start talking about it and educating as many people as I can about the variety of options, physical therapy and otherwise, and to discuss all the different types of headaches that are out there. We're going to go ahead and get started because, as you all know, I'm guessing either you yourself are living with head pain, or you know someone who is living with chronic head pain. And there's just so much to talk about on this subject. The goal with talking with all of you today is really, I have all these objectives written on here, but essentially is to start educating you on all the different types of headaches that exist out there, because there are so many kinds of headaches. And I also want to empower you with different ideas, resources, things that you can start using immediately to start managing your own head pain, or to help those that you care about with their headaches. So we're going to start talking about all of that tonight. We're going to talk about the different types of headaches, the prevalence of them, and again, things that you can start doing immediately to start managing your head pain. As we go through, if you have any questions, please ask. You can send them in the chat on the bottom, or in the little dots on the side. There's called meeting tools. You can scroll down and find Q&A, and you can ask questions through there as well. So I'm happy to ask questions. And if not, I'll give you guys a way to contact me when we send out the link for the presentation also, so you can email me questions after the presentation is finished. There really is an epidemic with headaches, and this is something that we need to bring attention to. Headaches are one of those invisible type illnesses. We can't see people with head pain, and so getting other people to understand the significance of them can sometimes be a little bit tricky. I always say it would be easier if we just had bandages wrapped around our head, because that would make something visible to other people that you're not feeling well, or that someone that you know isn't feeling well because of headaches. They are so prevalent that 1 in 10 people only do not experience head pain. So 90% of people at some point in their lives will have headaches, and 50 to 75% of adults every year experience some kind of head pain. Now, that doesn't mean that it's a chronic problem for those people, but it is such a common problem that basically at some point in one's life, they will experience some type of headache. 4% of those people develop chronic headaches, which in the United States comes out to being about 40 million people. And chronic head pain is head pain that occurs most days of the month, at least 15 days a month, and is present for 3 months or longer. I know many of you and many people that I see in the clinic have headaches that occur on a daily basis, and that's been going on for years. You are not alone. There are many people that have similar chronicity of their symptoms. 2% of the people that have chronic head pain have chronic migraine. And we use different classifications for headaches. Officially, there's more than 150 different types of headaches. So trying to differentiate what's what is really difficult, and finding the providers that are educated on different types of head pain can sometimes be even more challenging, depending on what resources you have in your community. The medical impact of headaches is huge, and it can be a strain and a burden to the medical system and to the insurance system when we are having difficulty managing them, or when they require a lot of different medical interventions. Migraine is so prevalent. It's in the top 5 of most common neurologic problems. And I'm going to imagine that a lot of you watching this know how difficult it is to get in to see a neurologist to start sorting through your migraine symptoms. Only 40% of individuals with migraine, though, have actually been diagnosed by a physician. So a lot of times people will say, oh, I have migraine, because they just think it's a headache that people get, and it may or may not actually be migraine. So I strongly recommend that if you suspect you have migraine, that you see a physician to discuss it. Only 10% of people with tension type headache have been diagnosed by a physician. So there are a lot of people flying under the radar, probably with migraine and tension headaches, that just haven't gotten to the right provider yet to receive an official diagnosis. Over 113 million work and school days are lost every year just in the United States because of people calling in sick for their headaches. And in addition to lost time in being productive in society, it also causes a big social impact on yourself and on your social circle. It's not uncommon to have to cancel plans because of headaches or not feeling well or recovering. And so we start to see a bigger withdrawal from social activities, and the financial impact of having to miss work and having to miss school costs the medical system, costs work, a significant amount of money. And migraine really now is the #1 cause for disability and missed work days for people under the age of 50. So this has a huge impact on our society, both in the United States and worldwide. There's two different types of headaches when we start to categorize them. The first type is primary, the second type is secondary, and there are common headaches that we see in each of these categories. So we're going to review what those types of headaches are, the most common ones that we see clinically here. And just remember, though, there's like 140 other kinds that I'm not going to have time to get through tonight. The difference between primary and secondary headaches is really what's causing the headache to occur. So primary headaches are a direct cause of head pain themselves. The most common types are cluster headaches, which is a type of trigeminal autonomic cephalgia. So that is caused by problems with the trigeminal nerve and that trigeminal nervous system. Different types of migraine headaches, tension type headaches, and the newest headache diagnosis that has come about in recent years is the new daily persistent headache, or NDPH. So we'll talk about those in just a second. There are also secondary headaches, and secondary headaches are head pain that is caused by some other disease or some other medical process. A lot of times we'll see the neck being a factor in a secondary headache, as well as medication withdrawal, tumors, strokes, aneurysms, and problems with the jaw, or the TMJ. So we're going to go over some of those primary headaches first and get into those in a bit more detail. The first one, again, that we mentioned was cluster headaches. Hopefully, if you have these, you've already received a diagnosis. They are a little bit more on the rare side. This is one of the only types of headaches that are more common in men than in women, and begins between the age of 20 and 40. It's just 0.4% of the population has been diagnosed with cluster headaches. We don't really know exactly where they come from. There does not appear to be a genetic link at this time. And you can't have an official diagnosis of cluster headaches unless you've had at least 5 episodes of cluster headache symptoms. Cluster headaches are episodic in nature, which means that you have chunks of time where you have head pain that is present, and then you have episodes of remission, just like you do with other chronic illnesses. So during those attack periods, you can have head pain that lasts days, weeks, months at a time where headaches recur, or you can have months at a time, years at a time where you don't experience any head pain. The main symptoms of cluster headaches are severe head pain. Some people call this an ice pick headache. Another nickname for this one is a suicide headache because the symptoms are so intense. And the pain associated with a cluster headache happens on one side of the head and can be in anywhere from 15 minutes to about 3 hours in length. And it happens with primary symptoms around one eye. And it can happen up to 8 times a day, every day during that chronic phase. The head pain also has to be accompanied by one or more of these symptoms that are listed here in order to receive a diagnosis of cluster headache. So those other symptoms include a stuffy nose, watering eyes, swelling of the eyelid, forehead or facial swelling, eyelid drooping, or constriction of the pupil. So think about just a stuffy nose or watering eyes and how easy it is for us to chalk that up to other things like allergies, especially this time of year. Hay fever season and the fall is kicking in. So there are a lot of symptoms that overlap, but it is that real intense pain around the eye that is characteristic of a cluster headache. These need to be managed medically. This is not a type of headache disorder where I would see someone in the clinic to manage head pain. There's a lot of different medication options. Again, you'd have to discuss this with your physician, but the most common things that we see clinically are Tress injections or nasal sprays, similar to migraine headache management. They can do nerve blocks in the occipital nerve, and that occipital nerve is a nerve right at the top of your neck, right under the skull. So nerve blocks there can help decrease the severity of head pain from cluster headaches. And people who try and take self-management at home with like Advil or Tylenol, those over-the-counter medications don't seem to have any positive impact on reducing head pain from cluster headaches. The other thing that is often recommended for this type of head pain are lifestyle modifications. So again, you'll start to see some patterns with this as we go through and talk about different headaches, but similar to migraines, you want to identify and avoid those triggers. Alcohol and histamines tend to be some of the biggest triggers for cluster headache. Nitroglycerin is also a trigger for migraine headache or for cluster headaches. And so nitroglycerin is a medication that is used to treat chest pain. So people who have episodes of angina or chest pain and are given nitroglycerin, if they develop this type of headache from that, they would know that they need to work with their doctor to adapt their medications. So moving on to another type of primary headache is migraine. Migraine, again, really kind of fits the bill of a headache, but we know now, and we're learning so much more about migraine, that migraines really are a neurologic disorder. They are more than a headache. And I could have made this entire presentation about migraine, and maybe I'll do that in the future where that's all we talk about. So we're going to kind of skim over the basics of migraine and talk about management for those as well. There's different types of migraine. One is a classic migraine, and a classic migraine is what people consider when they have an aura. And we'll talk about aura in just a minute. The non-classic type of migraine is a migraine without the aura. And an aura is any type of neurologic symptom that occurs typically on one side of the body prior to the onset of the head pain phase of a migraine. There can be changes or disturbances in the visual field, numbness in your face, weakness in muscles on one side of the body, dizziness, vertigo, and things like that. People who lose vision in one eye also, that can happen as well. I've gotten migraines on occasion too, and I do get an aura. So I'll get kind of like a flashing light, and you can see it in the periphery of your vision. I've also had migraines on occasion where I do get some facial numbness too, which is very alarming if you've never had that happen before. The presentation of migraine is different for everybody, so we need to keep that in mind. I could have a room full of individuals who have migraine, and every one of them is going to be different. Typically, the head pain associated with migraine is a U-shaped pattern across one side of the head. It is often a throbbing or pulsating pain that we would rate it as moderate to severe. The interesting thing with migraine and what differentiates it from other types of headaches is that when you have a migraine and you try and do activity will typically make that migraine pain worse. And that headache intense pain can last anywhere from 4 hours up to 3 days. So migraines can be very long in duration. In order to be diagnosed with migraine, you need to have 5 or more attacks of these symptoms with at least 2 of these symptoms in order to receive a diagnosis of migraine. This is one of those things that's frustrating because individuals with these symptoms, because they are so neurologic in nature and, facial drooping and numbness and muscle weakness, they obviously need MRIs and other tests, to make sure that their nervous system structure looks okay and there isn't something going on like a stroke or tumors or things like that. And all these tests come back normal, and trying to find someone to actually diagnose with migraine can sometimes be frustrating. The presentation of migraine, again, that head pain phase can last up to 3 days. But we know now that migraine is really this curve of symptoms that happens. And this curve that's on the slide here, this kind of bell curve pattern, is just related to head pain. These other phases that are written on here occur separately, and their intensities can be separately. So this bell curve is only for head pain, not these other symptoms. Okay, so we're going to talk about these presentation of a migraine real quick. The first thing that happens with migraine is the prodrome phase. We're going to get into this a little bit more in a couple minutes. Then you can have aura, a headache, and then postdrome phase. This entire cycle of a migraine episode can last up to a week. So we'll come back and get into symptoms of these in just a second. Migraines are usually triggered by a cumulative effect of symptoms. And these that are listed here are the most common types of triggers. These triggers, again, are different for everybody. And so it's a lot of trial and error to figure out which things and combinations of things are the things that will set off an episode of a migraine attack for you. Different food and food additives like MSG and nitrates, cheese, sour cream, peanut butter, a lot of people's favorite foods tend to be the triggers that bother them the most. Alcohol, particularly red wine, scotch, and bourbon. Stress, so I would say most of us have stress, so that's a trigger right there. Any change in routine, so skipping a meal or change in sleep schedule. This is really hard if you are working and work different shifts, or if you're in school and your schedule changes and fluxes every day. So any type of change in a routine can be a trigger for migraine. Changes in hormones, particularly we see this in women where up to 60% of women have migraine when their estrogen levels drop. I also see this often in people who are pregnant. Maybe they had migraines prior to pregnancy, and then they're pregnant and their migraines go away, and then they return after baby is born. So that's not uncommon too, or the other way around, where they've never had headaches before due to migraine, and then they become pregnant and have migraines. So that can work both ways. Intensive exercise can also be a trigger. This does not mean that you don't exercise. And also environmental situations like loud noises, flashing lights, certain smells and odors. But it's there's a lot of different things that can be triggers for you. And see, the list goes on. So there's even more things here. Medication overuse, problems with the neck. Now there's some controversy over this one, whether it's a chicken or the egg effect. Does migraine cause neck pain, or does neck pain cause the migraine? And there's some overlapping features of both. Changes in the weather, especially barometric pressure as it decreases, can change the chemical balance of our central nervous system, so around the brain, and that can be a trigger for them as well. Changes in altitude, so if you live closer to sea level and you go up to the mountains on vacation, that might be a factor in your migraine symptoms. Cigarette smoke and head trauma. So you can see that there are so many different types of triggers that impact whether a migraine will develop or not. And not all of these are things that are within your control. So I don't know anyone who's been able to figure out how to control barometric pressure and things like that. So you have to learn what your triggers are and work to control the ones that you can. We used to think that this accumulation of triggers, that there was a direct cause and effect. So if my trigger was red wine, then the previous theories and thinking of migraine was that if I had a glass of red wine, then I was going to get a migraine. We now know that that isn't necessarily true. The migraine bucket theory is what we practice today. And it's really an accumulation of triggers that over time that will set off an episode of migraine. So there could have been maybe a thunderstorm and you were up at night with the storm, and then a kid was sick, and then you had a bad day at work, and you had a glass of wine to deal with the bad day of work, and all of those things put together are all separate triggers that overflow your bucket or push you past that threshold of where your migraine tends to develop. And that's when an episode will start to happen. So a migraine starts, we think now, because of a neurovascular phenomenon. Neuro meaning a nervous system event, vascular meaning the circulation, and we're referring to the brain. So again, we talked about how we get this accumulation of triggers, and that's what sets everything off and causes this neurovascular phenomenon in the brain. From there, we now know that there is typically a drop in serotonin. So a lot of the medications that are out to help treat migraine help address this, where we try to keep serotonin levels up. And that drop in serotonin causes blood vessels in the brain controlled by the trigeminal nerve, which we mentioned earlier, to dilate. The dilation of those blood vessels stimulates a pain response in the trigeminal nerve. It's not the brain itself that has pain. The brain can't feel pain. And that causes a pain response in the brain stem. That pain response causes the release of another chemical called calcitonin gene-related peptide, or CGRP. And I know these are a lot of big words, but CGRP is another chemical in the brain that the newer medications on the market are trying to target to prevent the release of this chemical in the brain, because when this is released, it causes the dilation of blood vessels and inflammation of the meninges, or the covering layers around the brain, to dilate and become inflamed, which just contributes back into this whole cycle here. So we want to somewhere break this cycle if you're already in a migraine itself, or we want to stop it ideally with different interventions before the migraine cycle even starts. Again, we mentioned earlier that there's 4 different phases of migraine. We're going to talk about them a little bit more in detail. The first phase of migraine is called prodrome, and that's really a warning that a migraine is going to happen. These, again, are tricky sometimes because the symptoms are very easy to overlook. So this can happen hours to days before a migraine attack occurs. And symptoms can include anything from excessive yawning to difficulty concentrating, to mood changes, to food cravings, to sensitivity to light and sound, to feelings of dizziness or imbalance, and even fatigue. So these are things, again, that because of just life in general, a lot of people would overlook these. And because they start so far in advance of head pain, they're easy to chalk up to other things happening in life. Next would be the aura phase, and this used to be referred to as Alice in Wonderland syndrome. If any of you have seen the movie Alice in Wonderland, you know that the world looks very distorted to poor Alice when she drinks a drink and becomes too big and everything looks very small, or she drinks or eats a cookie and becomes very tiny and everything looks very large and distorted to her. And that's sometimes how people will describe this aura phase. So that's where that name used to come from. The aura phase itself, again, can be bizarre. The symptoms can be scary because this is a neurologic disorder and it relates to something happening in the brain. The brain can cause all types of things to happen. So you can have visual changes such as disturbances in your visual field. You can have trouble with your speech, like difficulty pronouncing words or knowing you want to say something, but it doesn't come out right, or the words are wrong, even though you know in your head what you want to say. And you can have neurologic symptoms like numbness, tingling, especially in the face and the arm. This is also where people can have episodes of vertigo and severe imbalance. The headache phase is where people experience head pain because of migraine. Head pain, again, is usually on one side of the body, and it can be accompanied by any of these other symptoms. So again, neck pain or stiffness, insomnia, congested nose or sinus pain. The newest research on migraine is showing that so many people are treated over and over again for sinus infections, and they really never had a sinus infection. It's just related to an undiagnosed migraine disorder. So if that's you and you have repeated sinus problems, this might be worth looking into. And a throbbing ice pick or drilling pain with sensitivity to light, sounds and smells, and sometimes even nausea and vomiting. Once that headache phase is done, again, that can last up to 3 days. We move into this recovery phase or post-drome phase of migraine. And this occurs hours or days following the headache until full recovery occurs. However, a new cycle of migraine can start before one completely ends. So you can go right into another cycle if your head pain is chronic in nature. People usually describe this post-drome phase as feeling like they have a hangover. There might be continued dizziness and imbalance, a sensation of depression or difficulty concentrating or comprehending words and visual input. I want to say right here also that with all of these symptoms that occur, not everyone goes through every phase of migraine. So you can have migraine and not have a headache. You can have migraine and only have vestibular or dizziness symptoms, or you can have migraine and only have ocular symptoms where you lose part of your visual field for a certain amount of time. The complexity of how migraine can present, because you can skip phases and not have all of these things present at one time, can make migraine very difficult to diagnose. Again, when we talked about the cycle of migraine, we talked about why or how different medications are trying to target the treatment of migraine. And again, I am not a pharmacist, I'm not a neurologist, but I do have to know what these medications are because my patients are taking them all the time and I need to know how they'll affect our patients. But there's two different classifications of migraine meds. One is an abortive medication and the other are preventative medications. The preventative medications are ones that are taken every day with the objective of trying to stop that migraine cycle from ever starting in the first place. And so there's different types of meds that are out there, like the CGRP blockers, calcium channel blockers, and beta blockers. You see these used also to treat blood pressure. Antidepressants can be effective, and anticonvulsants. So a lot of times I'll have patients that come in and they say, well, I'm not depressed, I don't want to take this med, but there are multiple uses for the medications. The migraine abortive medications are taken as needed when migraine symptoms do appear. So as soon as someone experiences any of the symptoms, hopefully before the aura and the head pain starts, these are designed to stop a head pain from beginning within 4 to 24 hours of the start of symptoms. So some come over the counter, like Excedrin migraine, and some are in prescription form, like Imitrex, Maxalt, or for those of you that have had to go to the emergency room to get an IV cocktail to stop your migraine pain, that is also an available option. We're going to move now into talking about tension type headaches. This is the last primary headache that we're going to talk about tonight. Tension type headaches are the most common type of headache, and people often mistake them as a migraine. I put in here to try physical therapy because physical therapy is effective for treating tension type headaches. Tension type headaches were originally thought to be a psychological problem. Again, it's an invisible illness. And so trying to understand the significance of head pain decades ago, people were just kind of chalked up as being crazy and making up their symptoms. We know that is not the case. These headaches are real. This also sometimes goes by the name stress headache. Tension type headaches can very often mimic migraine, but there are a few differences. People with migraine can have tension type headaches also. So it is possible to have two different types of headaches going on at the same time. The tension type headache, you'll have pain on both sides of the head, whereas again, in migraine, those symptoms are usually just on one side of the head. There tends to be a squeezing band around the head, so kind of like a headband all the way around with tension type headaches versus migraine, where it's usually just on one side of the head. There is sensitivity to light or sound possible with the tension type headache, but with migraine, you can have sensitivity to light and sound and smells and all of the things all at the same time. And the severity of head pain with a tension type headache isn't quite as intense as a migraine, and it doesn't change with activity. So if you're experiencing a headache that is there and it's kind of constant and it doesn't really change in intensity no matter what activity you're doing, it's more likely to be tension headache than migraine. Tension type headaches, though, can also be chronic and episodic in nature and can happen more than 15 times a month for 3 or more months at a time. And then you can go through periods where you never have a headache and then it can start up again. Again, it's very often that tension and migraine headaches will start and occur at the same time. You can have a tension headache and migraine at the same exact time with those symptoms overlapping, or you go through a migraine phase and then a new headache develops, and that might be a tension headache there. These types of headaches are not really known and don't have a known cause at this time. We used to think it was due to muscle contractions and spasms through the face, the upper back, and the neck, but more we feel that it is stress related and which causes a heightened pain response that generates that tension type pain. And then this new persistent daily headache, there's not a ton of information out here yet on this one. This one just came into the neurology world within the last 10 years, so it's still pretty new. This is a new onset of headache with pain happening daily for at least 3 months. The distinguishing feature of the new persistent daily headache is that people can usually tell you the exact date, time, and what they were doing when their head pain developed. And it can mimic other headaches. And so you first need to start to rule out any kind of other illness that could be producing those symptoms, particularly viral infections. But then, we need to go through all the diagnostic criteria for migraine, tension headaches, medication withdrawal, or different trigeminal nerve disorders to figure out what this headache actually is being caused by. Whatever headache it resembles the most, that is usually the type of treatment that it will respond to the best. So if you are diagnosed with NPDH and your symptoms are similar to migraine, then the interventions for migraine will be more effective for you than interventions for a tension type headache. We're now going to move into those secondary headaches and discuss what those are all about. Cervicogenic headaches is a big fancy word that really just means head pain that's coming from some type of problem in the neck. Okay, this is definitely something we see a lot in physical therapy. So things that can go wrong in the neck can radiate pain either down into the arms where we get numbness and tingling in the arms, but very frequently those same structures will refer pain up into the head. So things like herniated discs, problems with muscles, infections, arthritic changes in the joints in the neck, all of those things can refer symptoms up into the head and produce headache symptoms. The symptoms of cervicogenic headaches or headaches related to the neck might not have any relation to whether or not you actually have neck pain or not. So similar to migraine, where you may or may not have head pain, with this cervicogenic type headache, you may or may not have any problems that you would report with your neck, but pain can radiate from the neck up the back of the head to behind the eye. That's typically where we see these referral patterns of symptoms. And the pain is usually on one side of the head, typically on the side that has the most dysfunction in the neck. And an examination of the neck will reveal some stiffness and reduced mobility in the neck. And palpating or touching the different structures of the neck can reproduce those headache symptoms. So we know that if we touch the upper part of the neck and we generate increased headache symptoms, we know that those structures are responsible for generating that cervicogenic headache. Aside from palpating those structures and seeing what kind of effect we get from them, these types of headaches can be diagnosed through imaging. So we can do x-rays, CAT scans, MRIs of the neck and head and see structurally what's going on in there. And then sometimes they'll do nerve block injections, because if the nerve block gets rid of the head pain and they do the nerve block at a certain level of the neck, then we know that those structures, now that those nerves aren't firing and referring symptoms up to the head, we know that that was responsible for those headaches. So that's a lot of information that we've talked about so far about all the different kinds of headaches that are out there. But really, what can you do to take control of those headaches? And there's so much that you can do. So you have to stay persistent with it. The first thing to keep in mind is that, and I tell this to everybody, it takes a village, it takes a team. You need to really, really be a good advocate for yourself and keep working to find the right combination of healthcare professionals for you that help you manage your symptoms. So a lot of times it's not uncommon that you need more than one person on your headache management team, especially when your headaches are chronic in nature. It could be anyone from your primary care doctor to getting a neurologist on the team, or if it's related to your neck, working with an orthopedic physician, a PT, an eye doctor, because changes in vision can cause head pain too, massage therapists, chiropractors, nutritionists, psychologists and psychiatrists to deal with all of the psychological stressors that go along with chronic head pain too. So there can be a huge, and I'm sure I'm leaving people off of this list, but it really takes a lot of work sometimes to try and find the right practitioners to help you get control of your headaches. The first thing that I recommend doing is that if you are someone who is having a headache, more frequently, and you're experiencing all of these symptoms, start recording them and keep a headache journal. So this can be an overwhelming task, and you can just start with a couple of things at a time. But the first thing you want to do is document the severity of your headaches. And then other things that could be a trigger or contributing factor to them. So the duration and quality of your sleep every night. You can look at nutrition and see if any of the foods that you're eating are contributing to head pain. Some patients track the barometric pressure and the intensity of their headaches to see if that is a factor more toward those migraine headaches. And other symptoms that you might be having, like sensitivity to light or sound or smells. And what did you do, if anything, that you tried that helped make your symptoms better? This journal can help you identify patterns and triggers. It also gives you something to bring to your doctor's appointments, to your therapy appointments, to help remember what exactly has been going on, because it's hard to remember all the details of headache symptoms when they're chronic in nature. And you can do this old school. You can keep a regular calendar or pen and paper. That's fine. If you like technology and using a screen doesn't bother you, there are a lot of free apps out there too, like Migraine Buddy and Symptom Tracker, that you can download to record your symptoms as well. And then you have it on your phone, and it's available no matter where you're at if you need to record something right away. So there's no right or wrong way to track your symptoms, but I really highly recommend that if you are experiencing chronic head pain, that you definitely start keeping a headache journal. The other thing that we need to talk about is posture. Posture. It's every physical therapist's favorite thing to discuss. But really, everything that we do now is so forward, and it's not, and so our head comes forward and our shoulders come forward and our necks get tight up at the top, and the muscles in the front of the neck get weak, and our shoulders get tight, and our upper back those muscles get stretched out and weak also. And if we don't counteract that with working toward good posture, that can lead to additional things that can be a potential trigger for your headaches. It can cause changes in the neck. It can cause changes in the soft tissue structure, so the muscles and tendons. And that's just something else that can contribute to headaches overall, and lead to repetitive stress injuries. So text neck, where we're all looking down at our phones all the time, or trouble in our hands and wrists. So again, posture is an important thing. This is not a solution just in and of itself, but it is one thing that we can definitely work on. And if you don't know how, then physical therapy is a good thing for you. For those of you who are still working or who enjoy being on the computer at home to use social media or connect with other people, or if you're on even portable devices like tablets or your phones a lot, we need to think about ergonomics and how your workstation is set up for you to reduce those sustained stressors to the neck and to the upper back that tend to be the biggest contributors to chronic head pain. So when you are sitting at a desk or using a screen in general, that screen should be at or just below eye level, so that you're not straining your eyes or protracting your head forward to see exactly what's on the screen. And when you're using a keyboard or typing or holding a device, you want to make sure that your shoulders are able to be relaxed and that you're not in a position where you're typing up here and your shoulders are crunched up toward your ears the whole time. The other thing to help prevent that forward and rounded shoulder posture is the things that we use most frequently at our desks should be closest to you, and the things that you use less frequently should be farther away, again, to avoid that overreaching and repetitive forward motions that we tend to get into too common and too often during the day. The other thing we can do is be a little bit smarter about how we move and use good body mechanics. So I'm sure a lot of you have heard the phrase lift with your legs, and that is very true. The muscles in our legs are much stronger and more powerful than the muscles in our back and the muscles in our necks. And so making sure that you're lifting and moving while trying to keep your back as straight as possible, as you can see in this picture here, can be very helpful at decreasing repetitive strain and stress to the neck and to the back that could contribute to some of your headache symptoms. Okay, and you can see here that good posture is important no matter what you're doing. So when we are sleeping, keeping the spine in good alignment, you can see this guy down here laying on his side where his spine is in a straight alignment. Looking at how you're sitting throughout the day. I know most of us tend to be slouchers as we go throughout the day. These images here on this image are showing text neck. So again, the farther forward we're bending during the day and staying in that position, the worse off those symptoms can be. And then people ask me a lot of times about pillows and what type of pillow they should sleep on. There is not one good answer for that, but most often you want to make sure that you have support under the neck more than the head. So the head is cradled and the neck is supported. When you can't maintain good posture all the time, because who can do that? None of us can. You have to take a posture break. So for every 15 to 20 minutes that you are sitting in a sustained posture, move around, do some stretching. If you can't stand up and stretch, that's fine. You stay in your chair and stretch, or sit on the couch and stretch. And think about whatever posture you're in is what you want to move opposite of. So if you're spending your whole day forward on a computer or forward doing work, you want to work backwards and up in order to counteract that. Any one posture for any length of time, if you're spending all day in any sustained posture, is eventually going to be bad for you. So you want to look at what postures you're in most of the time and then move in the opposite direction. A lot of people also find relief with using heat and ice. And these are some stretches that you could start doing right away as well. And I know if you're interested in these later on, again, we're going to be sending this out, so you'll have these images and instructions. I would definitely recommend, these should never cause pain. And if you have questions about them, you should be working with your healthcare team to make sure that these are appropriate for you. But these are designed to counteract the most common postures that we see in the clinic that contribute to chronic head pain. So standing up and working on bending backwards and doing back extensions, working on wrist circles. So if you're using a keyboard or you're writing a lot during the day or you're texting a lot during the day, our hands tend to get crunched up. So opening up those fingers and moving your hands around can be very helpful. This upper trap stretch is a very effective stretch that I like to give to patients. This is one where you tip your head to the side and you get a big stretch through your upper trap, which is the muscle that sits, my hair out of the way, this muscle that sits on the top of the shoulder, and you just rest your hand on top of your head. You don't yank your head over, but you get a nice stretch along the side of your neck and you hold that. This feels really good, and you can do it on both sides. My upper traps feel very tight today, in case anyone was wondering. Chin tucks are a therapy favorite. So chin tucks are designed to help get rid of that forward head posture. And to do this one correctly, you get a very lovely and flattering double chin, and you keep your head level and pull your head straight back. And then you let it relax. This is a nice exercise because it does two things. Number one, it helps stretch out some small muscles that are at the base of the head and neck, which get tight from this forward posture. It also helps strengthen the deep neck flexors on the front of the neck that tend to get overstretched and weakened with a forward posture. So this is a 2-for-1 exercise. Again, to work on some better posture too, we can do some shoulder blade squeezes, which is just bringing your shoulders back and holding for a few seconds and then relaxing. And another one to address any hand and wrist tightness is to extend your hand back and pull to get a nice stretch in the wrist flexors. Okay, some more stretches. This first one, this levator stretch, is instead of tipping your head straight to the side, you angle your head so that your nose is pointing down toward your armpit. Okay, and you just hold your arms together to make sure that your shoulders don't pop up when you're doing it. The center one here is a mid-back stretch, and this mid-back stretch is holding your hands together, pushing forward and bending your head down. So this is a good one if you're standing and have to do a lot of work in an upright position during the day and you're not bending forward a lot. So this is a nice one for those of you that have that kind of activity level during the day. And the final one is this chest opener, where you hold your hands behind your back to open up and get a stretch across the front of your chest. And then from this position, what I like to add into that is also looking up. So from here, we get a nice stretch in the front of the neck as well as through the chest. There's other treatments that are on the market outside of physical therapy. So nerve stimulators are coming out on the market. Cephaly is one device, and there's a bunch of others out there that help block nerve pain signals that generate headaches. There's also one that gets implanted in the brain, a deep brain stimulator. These are not all FDA approved yet for headaches, so you would really have to work with your physician and discuss these different options. I don't know too many people who are using these yet, except for individuals who have chronic migraine. And there's also always alternative approaches. So, everybody responds differently to different interventions, and I would never discourage someone from trying something if it's beneficial for you. So, chiropractic care or acupuncture, using essential oils and smell is a different way to access the brain. It follows different nerve pathways than some of our other senses. So sometimes the use of smell appropriately, if you're not sensitive to smell, can actually be helpful with headache management. Using techniques like cupping, dry needling, or scraping tools like Graston or A-stim. These are techniques that we use in therapy quite often. Massage therapy and biofeedback, meditation, and ways to calm our autonomic nervous system. So getting our heart rate down, our respiration rate down, anxiety levels down can be very helpful. A lot of patients with chronic migraine are also using Botox effectively to help manage those symptoms. And of course, I say physical therapy for the last one because of that has to be my favorite. In physical therapy, if you do see a PT for your headaches, I think that you need to expect that you would have a full evaluation of your posture, how your joints move, the flexibility of your joints and your muscles, what kind of soft tissue mobility you have. They need to get their hands on you and feel what things are doing in there. If you have cervicogenic headaches, make sure that they're doing orthopedic testing. And if you have chronic migraine, that they're doing different neurological testing and checking your vestibular function and your eye function, all of those things. Making sure that your reflexes and coordination and all the things that your nervous system should be controlling normally are working properly. And then checking how well you move with your regular everyday things. And then in therapy, we'll work on posture. Again, we talked about those stretches already. Getting our hands on you to improve those restrictions with joint mobility and soft tissue mobility to try and improve your range of motion and your overall mobility. Strength training. There's a lot of research out there, especially on migraine and vestibular migraine, where strength training is actually very effective at chronic migraine management. So working with people to develop an effective strength training routine that's tolerated well by them. Stretching out nerves when they get tight too. Nerves have tissue around them that can become restricted. So there's stretches that we can gear toward that function as well. And working with people, again, on their body mechanics and how we're moving and how we're doing things, if we need to reduce strain to the neck or to the jaw so that we have less referred pain up into the head. And if there is vestibular migraine, again, that would be a migraine where the primary symptom is vertigo and balance and dizziness. Different vestibular rehab techniques are very effective at helping combat some of those things. So I want to thank all of you for being here. It's a lot of information, and I think each type of headache could be its own unique category, its own unique presentation, but we clumped it all together here tonight. I know we went a little bit over our time because we had those technical difficulties at the beginning. I want to give a minute if anyone has any questions. You can go ahead and type those in now. I also have provided my email address on this slide here. If you want to jot that down, you can send me a message individually. I'll leave this open for another minute or two in case anyone does have any questions. Otherwise, I just want to thank you so much for joining me. And I hope that you've learned something about managing your own headaches and head pain.